Today we will be reviewing GI accessory organ disorders. And remember, the accessory organs are the liver, gallbladder, and pancreas. We will review some lab and diagnostic tests. So serum bilirubin test. Remember, bilirubin is formed when old or damaged red blood cells disintegrate and release hemoglobin. So you have your indirect bilirubin that goes into the bloodstream and goes to the liver, where it's converted to direct bilirubin and expelled into the bile. Your bilirubin test will provide evaluation of the liver disease, biliary obstruction, or hemolytic anemia. Jaundice, which is the yellow coloring of the skin, is caused by high levels of bilirubin, and it's usually seen when the bilirubin is greater than 2.5. Before the bilirubin test, patients should be in PO. Your liver enzymes, you've got your AST and ALT, your LDH, and that's your lethal cholesterol. Remember, your L is lethal and H is healthy. You have your alkaline phosphate, and then GGT, gamma glutamyl transpeptidase. This helps diagnose liver damage. Serum protein, your total protein, albumin, globulin, and albumin-globulin ratio. Your serum ammonia level. Ammonia is a byproduct of protein metabolism. So ammonia goes to the liver, it's converted to urea, and then it's excreted by the kidneys. If a patient has severe liver dysfunction or altered blood flow, ammonia can't be converted, and the levels will increase, and your urea nitrogen levels will decrease. The serum ammonia level is useful when diagnosing hepatic encephalopathy and hepatic coma. You also have your hepatitis virus studies, serum amylase, serum lipase, and your urine amylase test. Remember, amylase and lipase are for the pancreas. First, we will talk about cirrhosis. So this is a degenerative disease of the liver in which the lobes are covered with fibrous tissue and the lobules are infiltrated with fat. So usually the liver can regenerate itself, but when cirrhosis is present, it is not able to do that. So repeated scarring of the liver decreases the liver's ability to replace itself. The liver is going to atrophy as blood supply diminishes. This is more common in males than females. The cause of cirrhosis is not always known, but alcoholism is one of the greatest factors leading to cirrhosis. There's a lot of different types of cirrhosis. You have alcohol liver disease, post-necrotic cirrhosis, biliary cirrhosis, cardiac cirrhosis, non-alcoholic fatty liver disease. So there's a bunch of different types. And cirrhosis can also occur from severe malnutrition. In the early stages of cirrhosis, you will see firmness over the liver, generalized weakness, malaise, and vague flu-like symptoms. In the later stages, you will see upset stomach, ascites, which is accumulation of fluid and albumin in the peritoneal cavity, jaundice, which is yellow discoloration of the skin, mucous membranes, and sclera of the eyes, further malaise, and spider telangiectasis, which is small dilated blood vessels with a bright red center point and spider-like branches. In this top left corner, you can see a picture of ascites, and again, that is when your fluid and albumin is accumulated in the peritoneal cavity, so the stomach cavity, or the abdominal cavity right here. Bottom right over here is your spider telangiectasis. These are commonly on the nose, cheeks, upper trunk, neck, and shoulders. You can see right here in the center red dot with spider-like things coming off, basically. On this top left, this is called caput medusae. This is a cardinal feature of portal hypertension. So portal hypertension occurs when there is obstruction of the portal vein that enters the liver. So this increased venous pressure is caused by scarring. The scarring compresses or occludes hepatic vascular system. So all of that pressure builds up, and then you've got your caput medusae. And then on the bottom right, palmar erythema. The palms of the hands turn red, and this is caused from circulating levels of estrogen that are increased when cirrhosis is present. This is just kind of an overview of the systemic issues that you'll see resulting from liver cirrhosis, and we will talk a little bit more about some of these systemic issues. So you can pause this and read that list over there to the side. Diagnostic tests, you will have elevated bilirubin, AST, ALT, LDH, and GTT, decreased total protein and albumin, elevated ammonia, low blood glucose, prolonged PTT and INR, decreased cholesterol levels. Test-wise, ERCP, this will help detect common bile duct obstruction. It helps visualize any kind of esophageal varices. It scans and biopsies the liver and ultrasounds the liver. And then paracentesis. This is when fluid is withdrawn from the abdominal cavity because we have that side effect of ascites. This is a diagram of abdominal paracentesis. So this helps relieve temporary relief from ascites. You want to make sure that your patient urinates immediately before the procedure because there will be a needle that's stuck into the abdomen. We don't want to accidentally puncture that bladder. Fluid will be removed over 30 to 90 minutes, and this is because we don't want to drop the blood pressure. So you do want to monitor your patient post-op for signs and symptoms of hypovolemia and electrolyte imbalances, and you want to check that dressing site for bleeding and drainage. Medical management of cirrhosis. So you want to eliminate the identified causes. So if it's caused from alcohol, you want to stop that. If the patient is on medicines that are hepatotoxic, you want to stop those, such as Tylenol. Diet therapy, you want to correct malnutrition, promote regeneration of functional liver tissue, and compensate for the liver's inability to store vitamins. So the patient should have a well-balanced, high-in-calorie diet, so 2,500 to 3,500 mLs per day, or calories per day. Should be high in protein, 75 grams, low in fat, low in sodium, so 1,000 to 2,000 milligrams of sodium, and include vitamins and folic acid. Antiemetics can be used. You do want to monitor for toxicity or buildup because meds are metabolized in the liver. If your liver is not working very well, then these medicines aren't being metabolized at a normal rate. They might also use Benadryl or Dramamine instead of Zofran, Compazine, Vistaril, or Atarax. Because the Zofran, Compazine, Vistaril, and Atarax are contraindicated in liver dysfunction. Complications of cirrhosis, fluid retentions. So to combat that, diuretics are commonly used to decrease fluid retention, such as furosemide or Lasix, hydrochlorothiazide or HCTZ, spironolactone or aldactone. Albumin may also be given to increase osmotic pull into the vascular space. So basically that shifts the fluid from where it is to where it shouldn't be to where it should be. The Levine peritoneal shunt. This is a jugular shunt that continuously shunts fluid from the abdominal cavity into the superior vena cava through a one-way pressure sensitive valve. And you can see a picture of that on the screen here. So basically it takes that fluid that is not supposed to be in the peritoneal cavity and puts it back into the bloodstream so the heart can pump it out to where it should be. You want to monitor for complications of this procedure, such as CHF, so congestive heart failure, fluid leakage from the ascites, infection at the insertion site, peritonitis, which is the inflammation of the peritoneal cavity, septicemia, which is bacteria in the bloodstream, sepsis, and a thrombosis in the shunt. And then also for fluid retention is that paracentesis, which we've already talked about. Esophageal varices are a complication of cirrhosis. So if we remember, we've got that portal hypertension. So we've got hypertension going into the liver. So the veins in the esophagus are going to become enlarged and engorged as a result of that portal hypertension. These veins are susceptible to ulceration and hemorrhage. Prophylactic treatment is going to include beta blockers like propranolol to kind of decrease that pressure. The varices can rupture as a result of anything that increases abdominal venous pressure. So coughing, sneezing, vomiting, Valsalva maneuver, any of those can rupture that varices. Sclerotherapy, which is injection of chemicals used to cause inflammation, followed by fibrosis and destruction of vessels that are causing the bleeding. So basically they inject the enlarged vessel, and similar to how they sclerotherapy the varicose veins, they inject it and kind of just shut down that vein. Band ligation can be used. Administration of octreotide or sandostatin. This slows the flow of blood from organs, internal organs, and that helps reduce pressure on that portal vein. And then also a surgical shunt can be used as treatment as well. A rupture of an esophageal varice is an emergency and should be treated as such. So if you have something that busts in the esophagus, in the throat, you want to make sure you maintain the airway. Administer vasopressin to control the bleeding. We want to stop that bleeding. And then they also might insert a Singstaken Blakemore tube to help control bleeding. Can also be used to clean out the stomach, so a lavage, and to suction things out of the stomach. So here's a picture of the tube that we're talking about. Now you have 3 different lumens. So one lumen is for the inflation of the esophageal balloon here. So we inflate this balloon to stop that bleeding. Lumen for gastric aspiration. So it will pull any kind of blood, or if there's gastric acid or food or anything, pull that out through this tube for gastric aspiration. And then inflation of the gastric balloon. This is the balloon. Basically, this makes sure that this the whole tube stays in place and it doesn't just slip right back out. Final complication of cirrhosis we'll talk about is hepatic encephalopathy. So this is type of brain damage caused by liver disease and consequent ammonia intoxication. So basically, the ammonia levels are too high in the body. Your signs and symptoms are going to start out as inappropriate behavior, disorientation, moves to asterixis, which is irregular hand flapping, and it's where there's extension and flexion of the wrist, and twitching of the extremities, and that moves to stupor and a coma. The treatment consists of supportive care to prevent further damage to the liver. And lactulose is going to be your first line of treatment. So basically, lactulose decreases the bowel's pH from 7 to 5, which decreases production of ammonia. And then it traps this ammonia in the gut, and it's also used, it has a laxative effect. So it traps that ammonia in there, and then the ammonia comes out through the feces. I will play this video. This is a demonstration of asterixis, which is that hand flapping. So you can see there is irregular hand flapping, extension and flexion of that wrist. Nursing interventions of cirrhosis. So you want to monitor vital signs closely. You want to monitor for GI bleed, monitor their fluid status. So check their eyes and nose, fluid, and they're probably going to be on fluid and sodium restrictions. And they might also be placed on diuretics if the diet modifications don't control that ascites and edema. Direct your patient to resources to deal with alcoholism if that is the cause of their cirrhosis. Establish an interest in your patient's well-being. Provide them with support groups out in the community. You want to provide patient education, so their need for rest and avoidance of infection, so hand washing, don't go around sick people. The importance of their diet. Range of motion, exercises, and repositioning every 2 hours to prevent skin breakdown, and avoid irritants of the skin. In people that have liver conditions, pruritus or itching of the skin is common, so make sure that the patient isn't overly scratching their skin, or if it's too dry, put some lotion on it. You want to also monitor lab values. Are they getting better? Are they getting worse? And place the patient on bleeding precautions as appropriate. So make sure they're using a soft bristle toothbrush, electric razor, blowing their nose carefully, and they're not straining when they are having a bowel movement. Liver cancer or carcinoma of the liver. Signs and symptoms of this, you'll see fatigue, weight loss, nausea and vomiting, itching, loss of appetite, a swollen abdomen, jaundice or pain in the abdomen, or it might radiate to the right shoulder. A lot of times liver cancer will mimic cirrhosis in the early stages, so diagnosis of liver cancer is difficult. The treatment is usually palliative and the prognosis is not very good, so your patient might enter hospice care. Chemotherapy and surgery may be used. Immunotherapy, radiation therapy, targeted drug therapy, and palliative care can also be used. It kind of just depends on what stage of liver cancer and what their prognosis is. Nursing interventions are going to focus on keeping the patient as comfortable as possible, and they are also similar to interventions for cirrhosis. Hepatitis is inflammation of the liver, can be caused by viruses, bacteria, or non-infection causes like alcohol or ingestion of drugs. You might see hepatitis G mentioned, but it only affects about 2 to 5% of the population, and it also coexists with hep C. All different types of hepatitis are going to vary in incubation periods, transmission, and prognosis. So, transmission-wise, Hep A is fecal-oral route. So, prevention for this is improved hygiene and vaccination. Treatment, there's not really any available treatment. Hep B can be transmitted through body fluids. Prevention is going to be blood screening, improved hygiene, and vaccination. Treatment will be the medicines. Hep C, body fluids are how it's transmitted. Prevention is going to be blood screening. If the patient is an IV drug user, make sure they're using sterile needles for drug injection. And then sanitary healthcare settings. Treatments for Hep C are going to be antivirals. Hep D, or this also occurs concurrently with Hep B, and this is transmitted through body fluids. Hep E is also occurs concurrently with Hep C, and it's also transmitted via body fluids. Health officials are required to report all types of viral hepatitis to the CDC. And prevention is going to be your best treatment. So hand washing, vaccines, use of condoms, use of sterile needles, depending on what kind of hepatitis. Your symptoms for hepatitis are going to vary a lot, but many of your patients are going to be asymptomatic. So subjectively, they might complain of malaise, aching muscles, fatigue, photophobia, chills, and abdominal pain. Objectively, you might see enlarged lymph nodes, weight loss, jaundice, and tea-colored urine. Diagnostic tests, they will have elevated bilirubin, GGT, AST, ALT, LDH, and alkaline phosphatase levels, prolonged PT and INR. Serum tests can be done for the presence of antigens associated with hepatitis, and a CT of the abdomen will reveal hepatomegaly, which is an enlarged liver. Your medical management for hepatitis is going to focus on decreasing the viral load. So interferon helps decrease the disease progression. This is an antiviral. There's going to be different interferon meds for Hep B and Hep C, but you want to monitor for drug resistance, and a complication associated with interferon is lactic acidosis, which is a buildup of lactic acid in the bloodstream. This can cause nausea and vomiting, abdominal pain, elevated pulse, muscle aches and weakness, unintentional weight loss, and liver failure. So if your patient has hepatitis and they're getting interferon and it doesn't seem to be getting any better and they seem to be getting worse, it might be because they have lactic acidosis from that interferon. Nursing interventions for hepatitis. You want to protect your patient from injury because they might have a decreased level of consciousness. They should be placed on bleeding precautions. You want to educate them on dietary information. So they need a diet high in carbohydrates and low in fats, and they should increase their fluid intake. You want to monitor eyes and nose, administer antiemetics as needed, and specifically for your healthcare personnel, we encourage, or they should be encouraged to be vaccinated against hepatitis B, and they should take care when handling dirty needles. Liver transplantation. So liver disease that's related to viral hepatitis is going to be the leading indication for a liver transplant. Other indications for liver transplantation: congenital biliary abnormalities, inborn errors of metabolism, if there is cancer of the liver, chronic end-stage liver disease. So with liver transplant, the source can be live or a deceased donor. So a live donor is only going to donate a portion of their liver, and then within weeks, the donor and the recipient's liver is going to grow back to the size the body requires to function. Types of liver transplantation grafts are in the picture right here on this lower right-hand corner. So a right lobe, which is like 60 to 70% of the liver, this might be needed for an adult or a large teenager. Left lobe, is about 30 to 40%, so that might only be for like a small teenager. And then the left lateral segment, 15 to 25%, might only be needed for infants or small children. The most common complication after liver transplant is rejection of the new liver tissue and infection. So medications used to prevent the rejection, it's going to consist of your immunosuppressants. So cyclosporine, Imuran, corticosteroids, Cellcept, Simulect, and then Simulect and Zenipax. These are used in combination with other immunosuppressants to reduce rejection rates. Nursing interventions for your patients that have had a liver transplant. You want to assess their neurologic status, monitor vital signs, monitor for hemorrhage, monitor their lab values, prevent pulmonary complications, so pneumonia, atelectasis, pleural effusions. Make sure they're coughing, deep breathing, using their incentive spirometer, and repositioning every 2 hours. You want to monitor their drainage tubes, so Measure and record drainage. Note the color and consistency. And preventing infection is very critical because these patients are fresh out of surgery and they are also immunocompromised because they are put on immunosuppressants to reduce the risk of rejection. So it's very important. If your patient has a liver transplant, you should make sure you're washing your hands, wear goggles, mask, gown, gloves, hairnet, shoe covers, everything. Usually after this surgery, the patients are in the ICU initially because the first 2 months after the transplant are very critical. Moving on to liver abscesses. This is basically a walled off area of infection contained within the liver. So it's like a big pocket of pus that is in the liver. If it's left untreated, it can be fatal. It can rupture or cause infection. Symptoms are going to include pain, fever, abdominal pain, and chills. The nurse should assess signs and symptoms. You want to monitor their liver function, so lab values. It is diagnosed with a CT scan. You can see this right here on the left-hand side, this big, darker, well, first, this is the liver right here. You can see the outline of the liver. And this dark circle here is your abscess. Usually it will be treated with IV antibiotics, but if needed, you can go in, the surgeon can go in and drain it surgically. So basically that is putting a tube, a catheter into that abscess and letting it drain out. You can see that in this picture on the right-hand side. Nursing interventions are going to be include monitoring the patient, monitoring their lab values, monitoring their therapy to the drugs that they are given, encourage fluids, and monitor their I's and O's. Cholecystitis or cholelithiasis. So, cholecystitis is inflammation of the gallbladder, and cholelithiasis is presence of gallstones in the gallbladder. Cholecystitis can be caused by an obstruction, gallstones, or a tumor. So if your patient is diagnosed with cholelithiasis, it doesn't necessarily mean they have cholecystitis, but they have gallstones, and those gallstones can build up, which can lead to cholecystitis. It can be acute or it can be chronic. Signs and symptoms, you will have your patient report pain in the upper right quadrant, and it'll radiate to that right shoulder. Usually the pain is abrupt in onset. It reaches peak intensity quickly, and it remains at that level for 2 to 4 hours. Usually they will have indigestion after eating foods that are high in fat, and the pain can be severe enough that it can mimic feelings of a heart attack. So they might have chest pain, increased pulse, and sweating. Diagnosis of this is made by ultrasound or a HIDA scan. Basically, a HIDA scan checks the patency of the cystic and common bile ducts and how well the gallbladder is functioning. Medical management is usually going to be aimed at surgical correction, so they will have to go in and take that gallbladder out. But with mild cholelithiasis, we can first start with bed rest, NG tube, NPO, antispasmodics and analgesics for pain, and possible antibiotics. The treatment of choice for cholecystitis, cholelithiasis is going to be surgery. There's technically 2 types of surgical procedures that we'll talk about. So the laparoscopic cholecystectomy, this is going to be the most common treatment for your cholecystitis and cholelithiasis. They use a laser or cautery to remove the gallbladder. And they use these trocars that you can see in this bottom right, or it's in the bottom right of the slide, but it's on the left-hand side of the picture. So those trocars basically have cameras on them, and they can move them around so that they can see good in there, and they don't have to open up the abdomen. This is going to replace the open surgical procedure 80 to 85% of the time. But sometimes they might have to do the open abdominal cholecystectomy. So the abdomen is opened and the gallbladder is removed. The recovery time is going to be longer than the laparoscopic one, and there's going to be a greater risk of infection for these. The patient will usually have a drain placed, but nursing care is going to follow the same path as the laparoscopic. However, you're going to add drain care, and the recovery will be a little bit more extensive. You can see some pictures of the laparoscopic cholecystectomy. So they put these trocars in the stomach at various points. And then the abdominal cavity is inflated with about 3 to 4 liters of air. And that is so that these trocars move around easier and that they can see better. So the laparoscope is inserted into the abdomen. The surgeon removes the gallbladder with the laparoscope. Advantages of this surgery: it's less invasive, the scarring is minimal, there's less pain, and they are quicker to return to normal activity. Post-surgical care, you want to assess and treat pain, assess vital signs routinely. You want to provide patient education. So usually with this laparoscopic one, they can go home the same day of surgery, but they should be informed that if they have severe pain or tenderness in the right upper quadrant, increased abdominal girth, leakage of bile-colored drainage from the puncture site, lower blood pressure, or like symptoms such as lightheadedness and dizziness and racing pulse, that they should come back in and see or call the surgeon. You also want to encourage early ambulation to help expel that air that is instilled in the abdominal cavity during surgery. Pancreatitis. This is an inflammatory condition of the pancreas, can be acute or chronic. Usually it's going to be caused by alcohol ingestion or biliary disease. Basically what happens is pancreatic enzymes build up and then they begin to digest the pancreas. So development of pseudocysts or abscesses can occur. Assessment of pancreatitis: severe abdominal pain radiating into the back. Pain is usually located in the left upper quadrant, but it might also be diffuse around the whole stomach. Fever, leukocytosis, which is elevated white blood cell count. Nausea or vomiting, hypotension. Turner's sign, which is bruising at the flanks. Cullen's sign, which is bruising around the belly button. And then if there is Turner's sign and Cullen's sign, this is associated with acute hemorrhagic pancreatitis. You can see here on the left-hand side of the screen, this is Turner's sign, so there's that bruising on the flanks. And then your Cullen's sign, that is bruising around the belly button. And an easy way to remember Turner's, T as in looks like it's on the side of the body, and then Cullen's, C, kind of goes in a circle around the belly button. Medical management for pancreatitis. So they will be kept NPO, and that is to avoid stimulating the pancreas. We want the pancreas to rest because pancreatitis is basically overproduction of the enzymes that are destroying the pancreas. They might have an NG tube to help avoid that pancreatic activity. The NG tube can help treat and prevent nausea, and it can help decrease abdominal distension. Medication-wise, they'll get analgesics and antispasmodics for pain, antiemetics for nausea, anticholinergics like atropine to decrease pancreatic activity, H2 antagonists, that's going to prevent stress ulcers caused by decreased gastric pH. So remember, the pancreas's job, besides secreting enzymes, is to secrete bicarbonate that goes to the stomach to neutralize acid. So if your pancreas isn't working, it's not going to secrete that bicarb to the stomach, and then that gastric pH is going to go up. Tube feedings might begin 24 to 48 hours after the onset of acute pancreatitis. Usually they're administered in the jejunum. That helps to prevent the release of pancreatic enzymes. Enteral is preferred to TPN because it's more nutritionally sound, it's less costly, and it has fewer complications. But if the patient is not tolerating that enteral nutrition, they might need to be switched to TPN. After pain is controlled for 24 hours, they can switch to clear liquid diet and gradually progress to thicker liquids and then pureed food. They should still avoid caffeine, though, because caffeine increases peristalsis and gastric motility. The person that has pancreatitis might need oral hypoglycemic agents or insulin because there is a destruction of the cells in the pancreas that help produce and release hormones that regulate glucose levels. Pancreatic cancer is the last topic we will talk about. So the most common risk factor in pancreatic cancer is smoking. Other risk factors are going to include exposure to chemical carcinogens, diabetes, cirrhosis, chronic pancreatitis, diets high in red meat, pork, fat, and coffee. Signs and symptoms of pancreatic cancer: anorexia, fatigue, nausea, flatulence, and a change in stools. Dull, steady pain in the epigastrium, or can be referred to the back. Weight loss, often gradual and progressive, is one of the earliest signs. Jaundice, pruritus, and a recent onset of diabetes can also be signs and symptoms. Diagnostic tests, it's going to be CT, ultrasound, and needle biopsy. Treatment is usually surgical, which is the Whipple procedure. It is also called a pancreaticoduodenectomy. So Whipple is definitely easier to say than that. Basically, it removes the head of the pancreas and the first part of the small intestine, the duodenum, gallbladder, and bile duct, and then the remaining organs are reattached to allow digestion of food normally after surgery. You can see a picture of that here on this right-hand side. So basically, they cut out this whole chunk right here and then just reattach the stomach to the small intestine. Radiation and chemotherapy can be used, but unfortunately with pancreatic cancer, a lot of your patients are going to have a very poor prognosis. So that is all I have for accessory organ disorders. If you guys have any questions, please feel free to reach out to me. Call me, email me, message me on Teams, or bring a question to the Q&A session.